So our next presenter is also an expert in MS, although just to change things up a little bit, he's actually going to speak about neurofilament light in a slightly different application in stroke, which should be very interesting as well. So please welcome Dr. David Leppert.
Thank you. Merci. So, good afternoon, everybody. I'm speaking as an MS expert on a novel application I have in mind for neurofilament light. You remember what Kevin mentioned in one of his slides, and we can imagine that slide by just going here on blind, I think. No? So the slide was, how many publications do you have in MS on NfL? That was that size of a bar, and then the rest of therapeutic areas. You remember that. And then on the right side was another panel. What is the size of disease burden? We have 2.4 million MS patients. That is vis-a-vis, that is this size, vis-a-vis neurodegenerative diseases, a tenth or less. Vis-a-vis cardiovascular and brain vascular diseases, it's 100th. So when we discussed, Julian and I, what shall I speak about, I decided that we should go for something that is somewhat a future perspective of application. I allude also to the fact that, these are my disclosures, I allude also to the fact that very much has been done on chronic diseases so far. And you see here from this slide what has been NfL being used for, or NfH being used for. Mainly these are chronic diseases, and there is a gap in acute diseases. We have heard at noon the hockey player and how he was left out with his disease from getting advice and also getting diagnostic tools being applied. And there are many of those diseases that we could go for. This is a chart from Charlotte Tönnissen, and it just exemplifies how dense the knowledge is across chronic neurological diseases on neurofilaments. It goes from HIV and frontal temporal lobe dementia to MS, etc. So that there's well established in chronic neurological diseases. So with acute diseases, Henrik spoke this morning about traumatic injury. I want to highlight that potentially it's not only NfL alone, but a combination of GFAP, tau and NfL that may yield even a better prognostic readout than just one marker alone. This is just recently published on traumatic brain injury in neurology. And Jens has, a few years back, analyzed a Canadian study where for the first time we saw that there is a prognostic value, not only that NfL at baseline when you have spinal cord injury is increased and correlates with the acute motor deficit, but it predicts also what will happen a few months later in the recovery phase. There are other examples on epilepsy, so seizures produce neuronal loss and hence an increase of neurofilaments, in this case heavy chain. And again from the Zetterberg group, autoimmune encephalitis would lead to an increase of neurofilament and other usual suspects. So the topic of my talk is about stroke, and I want to expand on that, also on what Florian mentioned. What for is it? We need to be clear when we go for a biomarker project, what shall it yield? And I just defined arbitrarily 3 buckets. There's of course a scientific value. We all appreciate if we can gain additional information, but there's an application in clinical trials. And I have listed the main topics of readout namely prediction of long-term outcome, detect what is not visible by current workup. And one example is, for example, spinal cord pathology in multiple sclerosis that escapes our attention. And it alludes to what I mentioned this morning, in that we should not fight against the MRI guild. We should tell them that there are some things you may not see with MRI that could be ancillary with a neurofilament test, namely spinal cord pathology. And of course, in the interest of phase 3 and phase 2 development, drug response. And then it's a question about individual monitoring. That is the latest stage of biomarker development. Can we achieve, shall we achieve that in these diseases, be it chronic or acute? I've selected some few papers to discuss with you on stroke. This one is from an Austrian group on small subcortical infarct, so a small vessel disease, and indeed there was an increase of neurofilaments being measured. No wonder when you know about the disease. The deficit of the study was it was cross-sectional, not longitudinal, and the Dichgans group from Germany just recently published this paper, where also Jens was involved in the analysis. They looked into two groups of two cohorts of patients. One was longitudinal, and they followed the patients after their stroke, and they selected everything. So not a specific type of strokes, but collectively what we call ischemic stroke. And they looked how NfL levels increase over time, and it peaks around day 7. And that, I think, is already a very telling finding. When you then stratify that for efficacy size versus controls, then you see this peak at day 7 more prominently. You see also in the second cohort that if you have further infarcts occurring, then that is an increase, leading to an increase 6 months later on NfL levels compared to a control group. The group speaks also about a term I find very, very interesting, and it alludes to the day 7 peak of NfL increase, namely secondary axonal injury. So the hypothesis, you have a damage being done by the stroke or by the infarction. That is the primary thing. And then there is a pathology occurring later that continues to produce neurofilament. So going back to the first group, you see here that the NfL increase over time here in hours is steeper and steeper the bigger the infarct volume is in these patients. So you see here. There is, of course, also here the correlation with age that becomes more prominent in the group of patients who have strokes. But you see here that how the infarct volume at day 7 then basically correlates with the levels of neurofilament. I skip on purpose over that part here. If you're interested to receive the slides, you're welcome to send me an email. What they did is then also to look into diffusivity. So with DWY analysis, they looked how the diffusivity changed in the hemisphere that was affected by the stroke as compared to the contralateral one. So basically the vanishing of neuronal tracts was reflected by imaging or imaging analysis. And you see here how this correlated beautifully with the serum level of neurofilaments. So indeed, there is a strong correlation not only on qualitative terms, but in quantitative terms on the size of stroke you can read out with an NfL measurement. Are these measures relevant for the patient? No, they are not. These are measures relevant for us as physicians, as trialists. What is relevant for the patient is, for example, what is his or her disability 3 months later after the stroke. So is the biomarker we are using reflective of something that is meaningful for the end user, or the end profitant of the analysis? And indeed, this is the case. They used here a very trivial modified ranking scale that is a 7-step scale between 0 and 6, namely no disability versus death due to the disease. And indeed, with a relatively small number, you can establish a correlation that serum neurofilament levels at day 7 were indeed predictive of what is a later outcome. And they tried also to rank that, the ranking scale here as the top, but the neurofilament level at day 7 was only close behind. So these are relevant readouts for decision making. I spoke about what is relevant for us for a biomarker. And I bring here a study, a preclinical study from colleagues from Stanford University who looked into a phenomenon that is puzzling us as physicians very much. So after the acute stroke, there is often a dementing process kicking in during the next few months in many patients, in the majority of patients actually, often leading just to depression, forgetfulness, not participating in family life, etc., which is not explained by recurrence of stroke. But there is a process, and that is the secondary axonal damage probably, that occurs post-stroke and is an endogenous inflammatory reaction. And I would like to lead you through this data. So this is data from human stroke patients, or from stroke patients, so it's human data. And you see that there is an infiltration of B cells in and around the stroke bed. It leads also to the production of immunoglobulins, and this is a quantitative or semi-quantitative analysis, how much more B cells you have and how much more immunoglobulin deposits you have in the stroke bed and in the halo zone. The group in Stanford tried then to model that in mice with occlusion experiments, so inducing strokes with 3 different models. And you see here what is the effect, and let's start with the bottom. What is the effect of an anti-CD20 therapy? That's a drug like rituximab or clelizumab or ofatumumab that depletes the circulation from B cells. So you deprive the resource for invasion into the brain tissue. That leads to a smaller size of the infarct. It leads also to a decrease in circulation of B cells. You can quantify then also that you lose less gray matter, and you can test in neuropsychological tests how the mice behave. So this is a spatial test for mice where they look into 4 tools, so for toys, and whether they're moved or not moved, because mice are curious on changes or detecting changes. So when you have moved the object for a second, go into that room, then they have more rears, so looking up to the toy. And that remains basically the same over the baseline week and week 7 in those mice treated with anti-CD20 therapy, so depriving of B cells and preventing this endogenous inflammation. Whereas here, after week 7, they have here a drop in their attention to go onto novelty. So interestingly, this is not happening at week 1. So there's a process going on that induces this neurocognitive deficit. So this is an opportunity where a biomarker like neurofilaments would be immediately applicable in the phase 2 study with such a compound or a similar compound, suppressing an endogenous inflammation. We then collaborated with colleagues in Stanford who got into an analysis of NfL in their blood collection of 25 patients with these sizes of strokes, so from minimal to quite dramatic loss of brain volume. And what we have found is that there is indeed, like in the German group, a correlation between neurofilaments at day 90 and the size of the stroke. Not so we have exhausted the laser, those being positive and those being negative, but the conclusion was that we will go on testing now a larger cohort of patients that is currently in control at Stanford University has a longitudinal workup of the cognitive deficit, and we are hopeful that we can make that link between a biomarker that is technically established and precise and accurate with something that is very relevant in stroke patients. So a disease that is somewhat very much bigger than MS and other ones, and where there's currently an unmet medical need for therapy. There is nothing here available therapeutically so far. Coming back on what could be achieved, yes, neurofilaments can be used in this setting for drug response. They can be, as you saw in this mice model, you could visualize something that is not visible by MRI, and you can predict the long-term outcome. And potentially there is also a monitoring effect for NfL being established, in that the German group showed that you can show recurrence of stroke after an initial event by an increase of neurofilaments. That is the part I skipped over and told you that you can ask for my slides if you wish. So I want to summarize what I tried to convey in the past few minutes. Stroke leads to an increase of neurofilaments. Neurofilament increase correlates with cognitive deficits. Therapy, in this case here for this preclinical study, anti-CD20 therapy, decreases neurofilaments and correlates with a decrease of cognitive deficits. And here comes the question about prospective and retrospective analysis. In order to validate that for clinical use, you should have a small prospective study that validates that concept. And if this is the case, as Jens has shown for the Solmani paper on using neurofilaments as an endpoint for phase 2 studies, that can be applied here as well in stroke studies, where so much has failed, so much effort was in vain. Maybe we have also, because we have not had a proper biomarker, missed out on something that would be efficacious in stroke therapy. With that, I would like to thank you for your attention. I want to show you one slide that Florian alluded to, in that what makes success in pharmaceutical industry developments. Biomarkers may not only be used in order to be positive, but also be used to terminate development early. And here are the three drivers of what makes success in the industry. It is being close to science, and second, having the guts to terminate something that is not functioning early. These are the success factors, and in both biomarkers are crucial. Thank you for your attention.
No questions? All right. We're going to continue on.